This is a real deep dive.
It is. It is. And speaking of complexities, let's shift gears and discuss mitral regurgitation, another common valve issue.
Okay.
So unlike mitral stenosis, where the valve's narrowed in mitral regurgitation, the valve doesn't close properly, causing blood to leak back into the left atrium.
So it's leaky.
Yeah, exactly.
Okay, so what causes this leaking?
Several things. Rheumatic heart disease, where the valve leaflets become thick and scarred, preventing them from sealing tightly.
Right.
Hardening and thickening of the ring around the mitral valve,
Right.
called annular calcification,
Got it.
that can distort the valve and lead to regurgitation. Endocarditis, an infection of the heart valves, can also damage the leaflets and cause leakage.
So the valve is damaged or deformed.
Yes, preventing it from doing its job.
Okay, are there other reasons why this might happen?
Yes, sometimes the leaflets are fine, but something's interfering with their closure.
Okay.
We call that dynamic mitral regurgitation.
Dynamic mitral regurgitation. Interesting. What are some examples?
Well, think about mitral valve prolapse.
Okay,
One or both leaflets bulge back into the left atrium, causing that leak.
got it.
Dilated cardiomyopathy, where the heart muscle's weak and the chambers are enlarged, can also lead to mitral regurgitation.
Right.
It's almost as if the enlarged ventricle is stretching the valve, preventing the leaflets from meeting properly.
This is being pulled apart.
Exactly. What else ischemia or lack of blood flow to the heart muscle can cause problems with the papillary muscles?
Okay.
Those tiny muscles that anchor the mitral valve leaflets?
So the support system is compromised.
Exactly.
Does it matter how much blood is leaking back?
It does. The clinical impact of mitral regurgitation depends on how much blood's leaking back into that left atrium and how quickly the condition develops.
So a small gradual leak is not as big of a deal as a large sudden leak.
That's right. The heart can adapt to gradual changes. If the mitral regurgitation develops slowly, the left ventricle can adjust,
Okay.
gradually enlarging and thickening to accommodate that extra blood volume.
So it's remodeling.
It is, and that enlargement helps maintain forward blood flow and prevents a sudden pressure rise in the left atrium and lungs.
But what if the leak develops quickly?
That's a problem. Imagine a sudden rupture of the chordae tendineae,
Okay.
one of those cords anchoring the valve leaflets. The left atrium and lungs might not have time to adapt. The pressure increases rapidly. And you can see symptoms like shortness of breath and even pulmonary edema.
So the suddenness is the problem.
Exactly. What factors influence how much blood leaks back?
That's a good question.
Well, it's more than just the size of the leak. The pressure difference between the left ventricle and the left atrium plays a role.
Right.
The higher the pressure, the greater the volume of blood flowing back.
Makes sense.
The duration of the contraction phase of the heart systole.
Okay.
That also matters.
How so?
The longer the systole, the more time there is for blood to leak back.
Yeah.
It's like a leaky faucet.
I like that.
The bigger the hole, the higher the pressure, and the longer you leave it on, the more water you lose.
Perfect analogy.
Right.
I was reading, though, that the volume overload in mitral regurgitation is less severe than in aortic regurgitation.
Interesting.
Even if the leak and pressure gradient are larger in mitral regurgitation? That seems counterintuitive.
Yeah, great observation. It comes down to timing.
Okay.
Mitral regurgitation leakage happens during systole, which is a shorter period compared to diastole, that relaxation phase.
Okay.
In aortic regurgitation, the leakage happens during diastole, which is a longer period.
So even with a bigger leak, it's happening for a shorter time.
Exactly. Picture a bucket with a hole. You'll lose less water if you dip it in and out quickly than if you leave it submerged for longer, even if the hole's smaller.
Makes sense.
It does.
Okay, so what clues might a doctor pick up on a physical exam that point to mitral regurgitation?
Well, one of the first things they might notice is a hyperdynamic apex.
Hyperdynamic apex. What's that?
It means the point where the heartbeat is felt most strongly
Okay.
is more forceful than usual.
So a stronger thumb.
Exactly. It reflects that left ventricle working harder to pump out that extra volume of blood.
Oh,
If the regurgitation is severe, they might even feel a vibration at the apex.
wow.
A systolic thrill, which indicates turbulent blood flow.
Okay.
Then sometimes you might feel a diastolic thrill, but that's more common if mitral stenosis is also present.
So many things to feel.
Yeah. It's a puzzle piecing it all together.
Right.
A late systolic pulsation in the left atrium felt in the area next to the sternum is another clue.
Okay.
This indicates the left atrium is overloaded with blood during systole because of that backflow.
It's getting hit with extra volume.
Exactly.
Fascinating.
It is. What about the heart sounds themselves?
The first heart sound, S1, is usually soft in mitral regurgitation.
Really? I would think it would be louder if it's leaking.
It seems counterintuitive, right?
Yeah.
But remember, those leaflets might be defective,
Right.
so they don't snap shut as forcefully.
Okay.
Also, the leakage often begins early in systole, even before the ventricle is fully contracting,
Right.
which can muffle the S1 sound.
Got it.
And then there's that loud systolic murmur that often accompanies mitral regurgitation,
Right.
which can mask the S1 sound entirely.
So it drowns it out.
It does. What about the second heart sound, S2?
Does that tell us anything? It can. In severe mitral regurgitation, S2 is often widely and variably split. Remember, S2 has two components: A2, the aortic valve closing, and P2, the pulmonary valve closing.
Right.
Now, when the mitral valve leaks severely, the left ventricle empties more easily because a lot of blood escapes back into that left atrium.
Got it.
This makes the aortic valve close earlier,
Right.
leading to a wider separation between A2 and P2.
Okay.
And the wider that split, the more severe the regurgitation.
So you're listening for the split and how wide it is.
Exactly. And if the P2 sounds louder,
Okay.
that could indicate pulmonary hypertension,
Right.
which can be a complication of mitral regurgitation.
Okay, so subtle differences again.
Yes.
Now, what about the other heart sounds, S3 and S4?
Yeah.
Do those tell us anything about mitral regurgitation?
They can. So S3,
Okay.
a low-frequency sound heard early in diastole.
Right.
It tells us about the volume of blood filling that left ventricle. Think of it as a sloshing sound as the ventricle rapidly fills.
So rapid filling, we might hear S3.
Exactly. And if the mitral regurgitation is caused by structural abnormalities of the valve, an S3 usually means the leak is significant.
Okay.
But if the regurgitation is caused by problems with the heart muscle itself, the meaning of S3 changes.
Interesting.
It might signal a stiff ventricle, not necessarily a severe leak.
So the meaning changes.
It does, and crucially, if you hear an S3, it essentially rules out significant mitral stenosis.
Oh, that's helpful.
Right. This is because with mitral stenosis, the blood flow into the ventricle is restricted. There's no sudden rush of volume to create that S3 sound.
So it can tell you what's there and what's not there.
It can.
When is S3 most likely to be present with mitral regurgitation?
You're most likely to hear it when there's a large backflow of blood, but the left ventricle is still functioning well.
Oh.
Or when the left ventricle is damaged and isn't pumping efficiently.
So a high-performing ventricle with a big leak or a struggling ventricle.
Yeah.
Now, what about that opening snap we talked about with mitral stenosis? Can you hear that in mitral regurgitation too?
You might. It might be present if the mitral valve leaflets are thickened and stiff,
Okay.
even if there isn't stenosis. Remember, the opening snap happens when those thickened leaflets reach their maximum opening.
It's about the quality of the leaflets.
It is. However, the opening snap in mitral regurgitation is often subtle, and you might only pick it up on an echocardiogram.
So we might not hear it.
Right. If you do hear it, it's crucial to distinguish it from the opening snap of mitral stenosis.
Right.
Remember, the opening snap in mitral stenosis is usually louder
Okay.
and occurs closer to the second heart sound because of that higher pressure in the left atrium forcing the valve open earlier.
Okay.
In mitral regurgitation, the opening snaps softer and happens a bit later.
Subtle, but you can tell them apart.
Exactly. What about that fourth heart sound, S4? So that low-frequency sound just before S1
Right.
occurs when the atrium contracts, pushing blood into a stiff ventricle.
Oh,
It's like a thud.
a thud. What does that tell us with mitral regurgitation?
Interestingly, you won't typically hear an S4 in cases of rheumatic mitral regurgitation.
Oh, interesting.
This is because the left atrium has had time to adjust to that extra volume and isn't having to work hard to push blood into the ventricle. It's relaxed and doing its job.
So no S4 means the atrium is happy.
You got it. But there are exceptions to this.
Okay, like what?
For instance, in acute mitral regurgitation,
Right.
where the onset is sudden,
Okay.
the left atrium hasn't had time to dilate. It has to contract more forcefully.
Got it.
And that's what creates the S4.
So it's putting in overtime.
You got it.
Yeah.
You might also hear an S4 in cases of mitral regurgitation associated with coronary artery disease.
Okay.
The heart muscle itself is damaged and stiff in these cases,
Right.
making it harder for the atrium to push blood into the ventricle.
So S4 is about a stiff ventricle, not an overworked atrium.
That's right. And hypertrophic cardiomyopathy,
Right.
where the heart muscle is abnormally thickened, can also lead to an S4.
Okay.
So the presence of S4 in mitral regurgitation could point to a few different things. An acutely overloaded left atrium or a stiff ventricle, depending on the underlying cause.
So context is everything.
You're absolutely right.
Mm-hmm.
Now let's talk more about that murmur of mitral regurgitation.
Mm.
We know it's a systolic murmur,
Right.
but are there different types associated with mitral regurgitation?
I thought they all sounded the same.
Not necessarily. So the classic mitral regurgitation murmur,
Okay.
it starts with S1
Yeah.
and continues throughout systole,
Okay.
ending at or even after S2.
Got it.
We call this a holosystolic murmur.
Holosystolic murmur.
It sounds like a continuous whooshing because the leaking happens throughout the entire contraction phase of the heartbeat.
Okay, but there are times when it's not holosystolic.
That's right. Think about mitral valve prolapse.
Okay.
The murmur typically starts later in systole
Okay.
and gets louder toward S2.
Okay.
This is because that prolapsing leaflet doesn't start leaking until the ventricle has contracted enough to push the leaflet back.
Oh, so it's a delayed leak.
Exactly. What else can cause a non-holosystolic murmur? Dysfunction of the papillary muscles can also cause a late systolic murmur.
Okay.
These muscles, remember, help control the valve leaflets.
Right.
And if they malfunction, the timing of that leak changes. The
The
murmur in acute mitral regurgitation might start loud and gradually fade.
Okay.
We call this decrescendo.
Why would that be?
It's because of those sudden pressure changes.
Okay.
Imagine that higher pressure in the left atrium forcing those mitral valve leaflets to close early,
Right.
reducing the leak later in systole.
So it shrinks as the pressure balances out.
A good way to think about it. And finally, in cases of mild mitral regurgitation, the murmur might be short and not extend to S2. The length of the murmur can sometimes indicate the severity of the regurgitation.
So shorter means less severe.
It can be an indicator, but remember, it's not a perfect correlation.
Right.
Factors like heart rate body habitus, the presence of other cardiac conditions can all influence the loudness of the murmur.
So it's not a simple equation.
It isn't. Is there a specific type of diastolic murmur associated with mitral regurgitation? Yes, there's a special type called the mitral flow murmur,
Okay.
which sounds like a low-pitched rumbling similar to the murmur of mitral stenosis.
So it can be tricky to tell them apart.
It can be. The cause is different.
Okay.
So with severe mitral regurgitation, the left ventricle becomes dilated and overloaded with blood.
Right.
During diastole, the ventricle rapidly fills,
Okay.
and that large volume of blood rushing through the mitral valve
Right.
creates turbulence and a murmur.
Okay.
It's like the sound of a rushing river filling a wide basin.
So the rapid filling creates the sound.
Exactly. And in this case, the valve itself is normal.
Okay.
It's the sheer volume of blood moving through it that causes the murmur. You often hear an S3 sound along with this mitral flow murmur,
Okay.
adding to the evidence.
So we can use the sounds to tell them apart?
We can, what else helps? The
Yep.
timing. The mitral flow murmur ends well before S1,
Right.
while the murmur of mitral stenosis often extends up to S1.
Got it.
Also, the mitral flow murmur has a lower pitch,
Okay.
a subtler rumble compared to that mitral stenosis murmur.
Okay.
And importantly, the mitral flow murmur is usually a good sign in mitral regurgitation.
Good sign. How so?
It suggests the heart can still handle that extra volume.
That's good to know.
Yeah.
Now, you mentioned earlier that the intensity of the murmur can vary.
Yes. The murmur of mitral regurgitation can change in intensity from beat to beat.
Wow.
This is especially true if the heart rhythm's irregular, like in atrial fibrillation
Okay.
or when there are extra heartbeats. It's all about the amount of blood in the ventricle.
So a more irregular heartbeat makes it more variable.
Precisely. More blood in the ventricle means higher pressure and a louder murmur. It's like squeezing a water balloon.
Okay.
The more water inside, the higher the pressure.
I get it.
And this variation in intensity is actually a distinguishing feature of mitral regurgitation.
Okay.
It helps us differentiate it from other murmurs that don't typically vary as much.
Okay.
From beat to beat, like the murmur of aortic stenosis.
So listening for the variation is another clue.
It is. Now, mitral regurgitation murmurs can sometimes radiate to unusual places like the right armpit or even the pulmonary area.
Why would that be?
It all comes down to the direction of blood flow.
Okay.
Imagine the leak in the mitral valve like a stream of water being redirected by obstacles.
I like that.
Usually the blood leaking back into that left atrium flows towards the back of the heart.
Okay.
That's why we hear the murmur best at the apex
Right.
and radiating towards the armpit.
Got it.
But sometimes the jet of blood takes a different path.
So the direction of the leak influences where we hear it.
Exactly. For example, if the leak is caused by an endocardial cushion defect,
Okay.
a type of congenital heart defect,
Okay.
the murmur might be louder on the right side of the chest.
Oh, interesting.
And if the leak is directed towards the wall separating the two atria,
Okay.
the murmur might be heard in the right armpit.
So depending on the direction, we hear it in different places.
That's right. Does this ever cause confusion with other murmurs?
Yeah, I wonder.
It can if the leak reaches the left atrial appendage,
Okay.
which is a small pouch-like structure extending from the left atrium.
Right.
The murmur might be loudest in the pulmonary area.
Okay.
This is the same area where you'd normally hear the murmur of mitral stenosis.
So the location isn't always clear.
It isn't. You have to consider all the features of the murmur,
Right.
the timing intensity radiation,
Yeah.
as well as other clinical findings.
So you're putting the puzzle pieces together.
Exactly.
So if you hear pansystolic murmur at the apex of the heart in a child, does that always mean mitral regurgitation?
Not necessarily. You always have to consider other possibilities, especially in children.
Okay.
A murmur like that could be due to a congenital heart defect called L-transposition of the great arteries,
L-transposition of the great artery.
where the aorta and pulmonary artery are switched.
That's a big difference.
It is. How can doctors tell those two conditions apart?
Yeah.
Well, when the aorta and pulmonary artery are switched, the blood flow in the heart is completely different.
Right.
In addition to the murmur, you'd likely see other signs.
What kinds of signs?
Strong pulsations in the neck veins, a loud second heart sound,
Okay.
specific patterns in the jugular venous pulse, and a slow heart rate. These all point toward a different diagnosis.
So it's a combination of signs, not just the murmur.
Exactly.
Yep.
Now, how do doctors differentiate between acute and chronic mitral regurgitation?
Okay.
The onset of symptoms is a key difference.
Okay.
Acute mitral regurgitation comes on suddenly,
Right.
causing shortness of breath and pulmonary edema.
Okay.
In chronic mitral regurgitation, the symptoms develop slowly over time as the heart adapts.
So the speed of onset?
Exactly. In chronic mitral regurgitation, the heart has had time to adjust to that leaking valve.
Right.
You'll usually see an enlarged heart on a physical exam or a chest x-ray.
Right.
In acute mitral regurgitation, the heart might not have had time to enlarge.
Got it.
So these signs might be absent. What about the heart sounds?
Okay.
The first heart sound, S1, is usually loud in acute mitral regurgitation because the leaflets are still structurally normal and able to close forcefully.
Oh.
In chronic mitral regurgitation, S1 is often soft, as we talked about earlier. And what about that fourth heart sound, S4?
Okay.
So that's common in acute mitral regurgitation. Remember, it indicates the left atrium is working extra hard
Okay.
to push blood into the ventricle,
Right.
which isn't used to such a high volume.
Okay.
In chronic mitral regurgitation, S4 is usually absent
Okay.
because the left atrium has had time to adapt.
So once again, working overtime.
That's right. The murmur, too, can give us clues.
Okay.
In acute mitral regurgitation, it often starts loud and gradually fades because that increased pressure in the left atrium can force those valve leaflets to close prematurely.
Right.
In chronic mitral regurgitation, the murmur is usually present throughout systole.
Okay, so that whooshing sound.
Yeah. Are there any other key differences?
I'm sure there are.
There are.
Yeah.
So pulmonary hypertension is more likely in chronic mitral regurgitation because the lungs have been exposed to higher pressure for a longer time.
Right.
In acute mitral regurgitation, that might not have had time to develop.
Okay.
So to summarize, it's the speed of onset. Heart size, heart sounds the murmur,
Okay.
and the presence of pulmonary hypertension that help differentiate between acute and chronic mitral regurgitation.
So you're looking at all these different factors.
We are. It's a multifaceted diagnosis.
Now, we talked about that classic whooshing holosystolic murmur of mitral regurgitation.
Right.
But you said that other conditions can also cause similar sounding murmurs.
Yes, that's right. Hypertrophic cardiomyopathy, or HOCM, and mitral valve prolapse, or MVP,
Okay.
can sometimes mimic the murmur of mitral regurgitation.
So how do you tell them apart? They all sound like whooshing.
Yeah, but there are subtle differences in the timing, location, and qualities of the murmurs.
Okay.
So, for example, the murmur of mitral regurgitation is typically present for the whole systolic phase,
Yeah.
that contraction phase of the heart.
Right.
The murmur of MVP is typically late systolic. Okay.
Starting sometime during systole and often growing louder towards S2.
Got it.
And the murmur of HOCM can be variable, but is often mid-systolic,
Okay.
starting after S1 and ending before S2.
So the timing is the first clue.
It is.
Yeah.
What else do you listen for? Location matters too.
Okay.
Mitral regurgitation's best heard at the apex of the heart
Right.
and often radiates towards the armpit.
Okay.
MVP is usually best heard at the apex too, but it might radiate more towards the left sternal border.
Got it.
HOCM is typically best heard along the left sternal border and might radiate to the apex,
Okay.
but not as strongly as in mitral regurgitation.
So even though they're all heard at the apex, the radiation is different.
It is. What about the sound itself?
Okay.
The quality of the murmur is another clue.
Right.
Mitral regurgitation often sounds soft and blowing.
Okay.
The murmur of MVP can be raspier or even musical,
Interesting.
while HOCM is usually harsh and can be quite loud.
Wow. So it's not just where you hear, but what it sounds like.
It isn't.
Yeah.
Anything else doctors consider?
Yeah. The presence of other signs.
Okay.
So for instance, with MVP, you might hear a click along with the murmur.
Look like.
That's the prolapsing leaflet snapping taut.
So a snapping, then a whooshing.
Exactly. With HOCM, you might feel two distinct thumps as the ventricle contracts. We call this a double apical impulse.
Double apical impulse.
And it occurs because the thickened heart muscle contracts in a jerky, uncoordinated way. It's almost like the ventricle is stuttering.
So it's stuttering.
Yeah.
It seems like you need to be a real detective.
You do?
Yeah.
What else helps with the diagnosis? Sometimes position changes or maneuvers can help differentiate between these murmurs.
Okay.
So, for instance, standing up usually softens the mitral regurgitation murmur,
Okay.
but standing often intensifies the MVP murmur
Okay.
because it increases that prolapse of the leaflet.
Got it.
Standing up can either increase or decrease the intensity of the HOCM murmur depending on the patient. The Valsalva maneuver can also help.
Remind me what that is again.
So that's when you forcefully exhale against a closed airway, like when you're lifting something heavy.
Okay.
This maneuver decreases blood flow to the heart
Okay.
and typically softens the mitral regurgitation murmur, intensifies the MVP murmur, and has little effect on the HOCM murmur. The second heart sound S2 can also provide some insights.
Okay.
So
I'm curious.
in HOCM, the order of the two components of S2 is often reversed.
Okay.
We call that paradoxical splitting.
Paradoxical splitting.
This happens because the thickened left ventricle takes longer to eject blood,
Right.
delaying the closure of the aortic valve.
So it's all about the timing.
It is. Are
Right.
there any other clues?
I'm listening.
The fourth heart sound S4.
Okay.
It's often present in HOCM
Okay.
because of that stiff ventricle
Right.
and less common in mitral regurgitation. It's usually absent in MVP.
So when evaluating a murmur, we're thinking about the timing location, the quality of the sound,
Right.
other associated findings, how the murmur changes with position changes,
Yeah.
the characteristics of S2 and S4. It's like a checklist.
It is. By carefully considering all these clues, doctors can usually differentiate between mitral regurgitation,
Right.
MVP, and HOCM.
Okay.
It's a process of elimination and pattern recognition.
That's amazing. Sounds like a challenge.
It can be.